Vulnerability in health research was first explicitly defined probably in 1979 in the Belmont Report. The report characterized the vulnerable as individuals and groups with potential limited capacity to give consent and or those liable to exploitation, such as racial minorities, the economically disadvantaged, the very sick, and the institutionalized. The report therefore required greater justification for the inclusion of vulnerable participants and suggested exclusion altogether from research as one way of protecting the vulnerable. But such exclusion turned out to be detrimental to their welfare, because no evidence could be generated for managing diseases or conditions specific to their needs. For example, the dose and safety of many medicines required by children is currently extrapolated from adult studies, even though it has been known for a long time that children are physiologically distinct from adults and are not just small adults. Similarly, limited data exists on the dose and safety of medicines for common diseases affecting pregnant or lactating women. As our understanding of research ethics matured, so did the thinking on vulnerability. The National Bioethics Advisory Commission in 2001 suggested that vulnerability is a condition of some individuals that puts them at greater risk of being used in ethically inappropriate ways in research, either because they are unable to provide an informed consent voluntarily or because they are prone to exploitation. The Declaration of Helsinki in 2013, in addition, includes another dimension to vulnerability, that of an increased risk of being wronged. And SIOM's Guidelines 2016, as well as other contemporary ethics guidelines, require that vulnerable persons or populations should not be automatically excluded from research. Instead, situations that create susceptibility to harm or coercion should be recognized and managed, and that all vulnerable groups and individuals should receive specifically considered protection prior to their inclusion in research. Scholarly assessment of vulnerability makes it clear that being vulnerable is not a simple yes or no situation. There are nuances. And the assessment of whether a person is at risk of being harmed or being wronged is not easy. To help us navigate this area of research ethics, we have invited Professor Florencia Luna, who has thought deeply about this topic, written extensively on it, and brought some clarity to the nebulous area of vulnerability. Professor Luna is Superior Researcher at the National Scientific and Technological Research Council of Argentina and Director of the Program of Bioethics at Flaxo. She is an expert for the World Health Organization and has been the president of the International Association of Bioethics, a member of the steering committee of the Global Forum on Bioethics and Research, and been a member of the Scientific and Advisory Committee of the Department of Tropical Diseases Research at WHO. She has won several prestigious awards and fellowships and is considered an authority on vulnerability in health research. Thank you, Professor Luna, for joining us. Can you tell us what is your definition of vulnerability, and how does a person or groups of persons become vulnerable?
Well, actually, it is not a definition, but what I've done is an analysis of the functioning of the concept. So it can accept multiple and different definitions, and that's part of its beauty. What I want to explain first is that there are like two spheres of analysis of this concept. There is like a conceptual ethical sphere that addresses the conceptual and theoretical problems the concept presents. That is, how the concept should be understood. And there is also a political ethical sphere that considers the relevance and usefulness of the concept. So that means how it should be adequately used. But even if these are two different spheres, they are deeply related. And if we don't have a good theoretical and sound concept of vulnerability, we will not be able to use it reasonably. So it is very important, the conceptual analysis that I will present, and that I think is part of what I've been mostly doing during more than a decade. So I began analyzing the conceptual sphere, but lately I began also showing how to use it adequately. So that is part of what we will be doing now.
What is the problem with identifying certain people or groups as vulnerable?
The Belmont report provides, to my view, an incorrect conceptualization of the vulnerable groups. It corresponds mainly to the traditional analysis. It's not only the Belmont report, but you can find it also, for example, in guidelines, SIOM's WHO from 2002 as well. So what is the problem with this approach? Well, one of the main problems of this approach is that it's based in what is called subpopulations. We are targeting subpopulations. The problem with targeting subpopulation is that they then you stereotype a population. It implies putting someone a label that cannot be taken out easily. It fixes the content, and this cannot be changed easily. We can say also that we may identify subpopulations that may not be vulnerable, or vice versa. So we can have that problem. For example, Carol Levine and other bioethicists that wrote a very important article in 2004 point out that it is an irrelevant concept. And they say the concept is so nebulous that it becomes at most meaningless. It is so broad that in one way or another, everybody is vulnerable. So that is part of the problem. For example, guidelines from SIOM's 2002 provide a long list of vulnerable populations, and they speak then of an overpopulation of vulnerable groups. But also, this idea of a subpopulation approach makes two assumptions. First, that there is a baseline standard for default paradigmatic research subjects or participants. Mature, moderately well-educated, literate, self-supporting person, which is like the ideal of the research subject, and vulnerable populations are the ones that are the default of that paradigm. And this is a problem. This is an idealization of research subjects. So this is also another problem this kind of conceptualization of vulnerability brings in. And this is why conceptualizing it in the right way is so important.
Can you please explain what you mean by layers of vulnerability, perhaps with real examples?
What I do in my own conceptualization of this concept is to explain, as I was saying at the beginning, the functioning of this concept. And the functioning of this concept is relational and dynamic. So this means the concept interacts with the context. We should think not in subpopulations, categories, mere labels, as I was explaining before, but in layers. What are layers? Well, in my view, there are several layers of vulnerability. a person per se is not vulnerable. For example, a woman per se is not vulnerable, but a woman that lives in a country that does not respect her reproductive rights acquires a layer of vulnerability. But if this woman is a woman of a middle or upper class and she needs to terminate her pregnancy, she will find ways to do it more or less safely. However, if she is a woman from a resource-poor setting, she will acquire another layer of vulnerability. And if she is illiterate, another more. And if she belongs to an Aboriginal group, another one. So it is not a category. We do not exhaust a category. We have different layers that may overlap and render the person more and more vulnerable. So layers may coexist and layers may be minimized one by one. And this is very, very important. So, for example, we can say that, in my view, some groups that traditionally are not thought as vulnerable are, for example, physicians and physicians in developing countries where there was not the protective equipment to treat patients at the time of the COVID pandemic were or had a layer of vulnerability. They were literate, they had power and whatever you wanted, but at that situation, they acquire a layer of vulnerability that could be very, very harmful for them and their lives. There is another important concept I want to bring him here. And this is that layers of vulnerability are dispositions. They are, what does this mean? Well, they are latent until a stimulus condition triggers them. It's like a cube of sugar that is soluble and it dissolves when it is introduced in a liquid. The stimulus condition in this case is the event of introducing the cube of sugar in liquid. This event triggers vulnerability. In this case, solubility. The same happens with vulnerabilities. They are latent and there might be certain facts that may trigger that vulnerability. So we have to be really very careful and very conscious of what these facts could be. If that stimulus condition, if that triggering doesn't occur, the layer will never be actual, because as I was saying, it is something latent. For example, we can again think, in this case I was bringing from my region, which is Latin America, and we can think in a trial that is done in women of childbearing potential. And if in this clinical trial we do not provide, for example, anticonceptives, and we do not explain how to use them carefully, etc., this may trigger that vulnerability. And we will see that this can be very, very harmful. So triggers and identifying triggers is fundamental. But another issue that is also fundamental is thinking that there are some layers of vulnerability that have a, what I call, cascading effect. So these layers of vulnerability may exacerbate existing vulnerabilities or generate new vulnerabilities. it is like a domino where you push one and then you have all these steps going down. So this cascading effect is really very, very harmful. And if we go back to my previous example of the possibility of getting pregnant during a trial, and we can add that may have some teratogenic effects in the fetus, we will see that this layer of vulnerability has this cascading effect. Why? Because, for example, doing a trial in a country that doesn't allow termination of pregnancy and the woman gets pregnant in the first months, for example, when the teratogenic effect is even more harmful, it's really dangerous, and we can think that it is dangerous for her and harmful for her if she goes for an illegal abortion. She may end with several health problems and even death and even in jail. But if she continues the pregnancy, she may have a boy or a girl with several health conditions, genetic defects that she may not be able to cope with. So this is why I think that in this case, we are in face of a layer of vulnerability that has this cascading effect. For example, we can think that normally men leave women when they have babies so complicated, so she will end alone, taking care of this baby, having to maybe problems with her work, leaving her work, having problems to get where to get help for the child. So you can see how this concept is so important because it shows how harmful this cascading effect may be. So these are, I think, the most important features of this conceptualization I make of this concept. So this concept of layers of vulnerability is much more, adequate, rational, to the point. It's what happens in reality. Sometimes we can say it's more complex. It's more difficult to see what layers are. But what I think is that life is complex. We cannot think that just ticking boxes and putting labels to people will solve problems.
How should one proceed to assess and manage vulnerability in the field situation?
Well, as I was saying, I think layers of vulnerability may be harmful. There might be cascade effect of layers that may show they are more harmful ever. We may also need to identify triggers, those stimulus conditions I was speaking before, because that is also fundamental to see if that layer of vulnerability that is latent will become actual. So what we have to do to assess vulnerabilities is see how probable these layers are, if there are cascading layers, and what are the triggers that may be over there in that situation, in that context. So we have to see how probable they are and also how harmful they are. Because as I was saying, there might be several layers of vulnerability, and we have to be able to assess which of them are more harmful and more probable. And for that, we will have to consider triggers, because, for example, that same protocol I was mentioning, if it's done in Switzerland or France or the UK, where there are no problems with termination of pregnancies, the layer will not become actual. There is no layer there. But if we do it in El Salvador, where it is forbidden to do any kind of termination of pregnancy, we are in problems. And we can see those different layers that may begin to pass from that latent situation to an actual one, and how dangerous and harmful they might be. But another thing that is important to think is, what are our obligations? And I think that we have first to avoid exacerbating vulnerabilities, that our protocol or our policy, if we are thinking in research ethics, be so that it does not, when we introduce it or when we do it, exacerbate vulnerabilities. The second possibility is eradicating vulnerabilities. That is the must, or what we can tend and try to do, but sometimes that is really impossible. When we are speaking of some socio-economic situations, when we are speaking of literacy and things like that, we cannot change that. Or even abortion, a researcher cannot change a law, so they cannot eradicate vulnerability. In that case, our third obligation will be to minimize layers of vulnerability. For example, in the case of the example I was saying of this trial, it is, for example, by providing anticonceptives, normally by providing two kinds of anticonceptives. That is what we traditionally call the safeguards. When we are speaking of vulnerabilities, we traditionally speak of safeguards, protections we must provide to these people. But another issue that is very important, and it's not really stressed in the traditional view, is also empowerment. Because these women, if they do not know how to use these anticonceptives, how and when, and if they do not, their sexual reproductive life, they will not be able to use them adequately. So it is also empowering them, giving them the tools to be able to have that kind of strength. So I think it's very important, safeguards and protections, but also empowerment in many cases.
You mentioned that vulnerability is contextual. Can you give an example for the contextual nature of vulnerability?
It depends a lot on the situation, on the case. For example, there's an article I wrote with Cheryl Vanderpool, where we take the case, and this is not research ethics, but public health ethics, the case of cord blood banks in Argentina some years ago, because the situation changed. And the situation was the following. For example, when you went to the to see your gynecologist, you will find all the advertisement of these cord blood banks. And there was all these photos of healthy babies and making you feel bad if you didn't store the blood of your newborn through one of these cord blood banks. In this case, the ones that were really vulnerable or acquire a layer of vulnerability, as I like to say, were middle-class women that went to private gynecologists that had all this advertisement in their clinic. In Argentina at the time, there was a public cord blood bank that was functioning in one of the main children hospitals, and they could store the blood of your newborn. For example, if you had a problem with his or her sibling and you needed that cord blood, and the transplant is free and they are covered. So in that case, women of resource-poor backgrounds were much more protected and were better than middle-class women that were with all this publicity and making fail women or parents badly if they were not spending all this money. Even grandparents were providing the money to do the storage of cord blood. So what I want to say is that the situation may render a person that normally is not vulnerable or acquire a layer because she's still middle class, she still have many other resources. But there is this layer that is operating. As I was saying before, also, a physician in our countries, in Peru, for example, that was having waves and waves of COVID, was vulnerable because he or she didn't have the adequate equipment to protect themselves. So it will depend a lot on the situation. Obviously, in poor resource countries, there are many people that are in worse situation. But I think that we have to get out of this simplistic analysis and we have to see the situation and what is happening actually, currently in that place, with that protocol or with that public policy.
What is the role of ethics committees in evaluating vulnerability, especially in the context of international health research?
Well, regarding how to think and what happens in the international context when these protocols are done in another country, I think it is fundamental to have the assessment of the Research Ethics Committee, the local Research Ethics Committee. I think they know better their population. They know if there are problems of, for example, literacy, if it is a very patriarchal society, if, for example, there are some endemic illnesses. So it is very important, their analysis. I also think that there is a tendency of research ethics committees to be quite adversarial and to think they have the power, and sometimes they are seen as putting obstacles to researchers. I think that's not the right way to proceed. I think we shouldn't think ethics committees as adversarial, but as collaborators, and that they have to think through with researchers how to build the better and the best protocol, and the one that will protect in the better way and empower in the better way their participants. So I think that is fundamental. And another crucial issue that I suggested in one of the questions is that we should avoid checklists where we say, well, this person, I don't know, is from an Aboriginal group, so she's vulnerable, or he's vulnerable, or she comes from, I don't know where, she's vulnerable. I think that we have to avoid checklists, and we have to learn to deliberate and to think through the context, the situation, the persons, the actual and current person that will be engaged in that protocol. If we do not learn how to think through, we are in problems. And that is why sometimes committees from the north, from the south, may be overprotecting, and at the same time, when they overprotect, they disprotect. And this is the case, for example, of pregnant women. Pregnant women have traditionally been overprotected, not because of them, because of the fetus, and because of cases, horrible cases as the thalidomide in the 60s. So what had happened? We had not recruited pregnant women in trials, and the problem is that pregnant women fell ill when they are pregnant, and ill women get pregnant. So we need to do research with them carefully, with having all the protections that is needed, but if not, we are disprotecting them. Some years ago, I don't have the data now, there were like 12 drugs that were really tried in pregnant women, and we use lots of drugs with these women, but we do not know. And also the cycle of pregnancy is very different, the first trimester, the second, the third, and we need to know. We cannot disprotect because we are supposedly overprotecting. So that's part also of the problem, and that's something that we have to work throughout, I would say, in the north, in the south, and these are part of some of the problems research ethics committees, researchers face. It is easier to do protocols and trials with men, but we have half of the population are women. So we need to do it in women, we need to do it in men, we need to do trials in pregnant women, and we have to find the ways to do it safely or as safely as possible in order to protect them, really.
How do you think one should approach the issue of researcher vulnerability?
Well, I think that I explained something similar regarding physicians during COVID. And we can say that, in a way, they may have a layer of vulnerability. Sometimes they are not the ones that design the protocol. They cannot argue really to change things. So we can say there are certain layers of vulnerability that may be acquired there, and it will depend a lot on what the relationship is with the PI in the north, where this woman or man is working.
What has been the benefit from and the impact of thinking about vulnerability as being layered?
Well, I think that my proposal, as I was saying, reflects flexibility and dynamism. Layers describe better what happens in the real world, and in this sense, it can address complexity. As I was saying, the real world is very complex, and we need to cope with it and find ways to incorporate this complexity and give some answer to it. I think that the theoretical explanation I give, for example, the devastating and incremental harms implied by cascade layers and the possibility of harmful layers and the triggers are outlined and in a way provide a better assessment, and that research ethics committees may consider this when they are doing their assessments in a more careful way. I think it gives concrete guidance of how to do the assessment and which are the obligations. And one important thing I should mention is that it has influenced very important guidelines in research ethics. And this is the case of the CIOMS WHO guidelines of 2016 the new guidelines, and where they explicitly say, and this is guideline 15, that the traditional approach is not the one they will follow. They seek to avoid considering members of entire classes of individuals as vulnerable, but more importantly, when they explain this in the commentary, they speak of there are different characteristics, different factors that may coexist, that overlap, that are dependent on the context, and these characteristics, factors, etc., are my layers.
Thank you, Professor Luna, on that very thoughtful analysis. To sum up, in brief, it is incorrect to treat some subpopulations, such as the illiterate, the poor, women, pregnant women, as vulnerable by definition, because that assumes incorrectly that there is an ideal population that is not vulnerable. Anyone can become vulnerable depending upon the context and situation. Vulnerability is a nuanced concept and requires a thoughtful deliberation. In the context of health research and public health, vulnerability means being in a situation that allows one to incur greater harms or additional wrongs as compared to others. Vulnerability should be considered as being layered. Exposing one layer of vulnerability can have a cascading effect that, depending upon the context and situation, exposes further layers, progressively increasing a person's vulnerability. Research ethics requires that vulnerable persons be provided protections in the context of health research, and when needed, be empowered to protect their interests. Protections do not mean no research on vulnerable people. Protection means enabling research on vulnerable persons on issues that are relevant to their needs while empowering them and protecting their interests. Vulnerability and relevant protections can be assessed by asking questions related to context and asking how the vulnerability could be eradicated or minimized, and how the person could be empowered to overcome their vulnerability. In the context of international health research, one should listen to the local ethics committee, avoid a checklist approach, learn to deliberate and contextualize, and demonstrate thoughtfulness, flexibility, and a dynamic approach.